Infusion and specialty pharmacies are both dispensing specialty products today. So the UM programs that we see most important for a plan to consider, on the traditional specialty side, so these are drugs that are typically either mailed to the patient or sometimes picked up at the retail environment. Those programs are really focused on minimizing what we call the cost to treat. So don't pay $40,000 for a dose of a drug when you can use a different, maybe when you can dispense one pill instead of two pills, actually getting to the same dose, but the cost can be half as much. I mean, it's just logical, but what we see is a lot of PBMs today don't have those kind of edits programmed into their system. So very simple, starting with the very simple, knowing what drugs have that, what we call dose optimization opportunity. A drug like Afinitor comes in 4 different strengths. We see prescriptions come in the door at Walgreens written for 3 tablets of the 2.5 milligrams, take once daily. That same prescription at dispensing 1 of the 7.5 milligram strengths would decrease the cost out of that script by $13,000 per month. So it's pretty amazing. And these keep in mind, these claims actually paid. We receive them at Walgreens Specialty Pharmacy. They first adjudicate before they get reviewed for the opportunity. So these actually paid through the PBM, and then we intervened on it, called the physician, and adjusted that dose down to 1 of the 7.5 milligram tablets. Lowered the pill burden for the patient, decreased the cost by $13,000 just that 1 month for the payer, which is a very impactful utilization management program. Very, very straightforward, easy to understand, but not every pharmacy is executing on those today. There's definitely more complex utilization management opportunities over programs in specialty pharmacy. We have a very integrated and robust oral oncology management program, which we call cycle management program, that is tailored to every oral oncolytic agent specifically, that focuses on making sure the patient understands how to take their medication, what side effects they may experience, what to do if they have those side effects, and knowing that about 1/3 of oral oncology patients for the drugs that are the key drugs never fill the second prescription. They only get 1 fill and never come back. We'll also, what we do, what's called monitor dispense or split fill, where we're giving that patient 2 weeks of therapy to initiate them, and then dispensing the next 2 weeks of therapy if they were tolerated the first 2 weeks of therapy. And we can actually have that program rolled out into months 2 and months 3 of therapy as well. So again, that can reduce the cost by half directly, but also reduce indirect healthcare costs because we're educating the patient on how to take their medication and what to do for side effect management. On the infusion side, there's a number of programs wrapped around nutritional services, but I'm going to focus on immunoglobulin because it's a great example. It's a very complex medication that can be used for a variety of different diseases. Very wide dosing, very large amount of dosing variation within it. So, and it's infused, has to be infused by a nurse. So several things that you can do as part of a program. First is make sure that the strength that the physician wrote is appropriate, is the lowest cost-effective way to treat that patient. If you look at what scripts that we see come in the door for treating patients with an exacerbation of myasthenia gravis, it can be written, we see it written as 2 grams per kilogram for the patient to be infused. The studies that we refer to the physician actually show that there's no increased efficacy from the higher dose versus using 1 gram per kilogram for that patient population. So we'll actively attempt to have the physician lower the dose for that patient to receive, prior to that infusion occurring, which it would reduce the cost of that therapy by half. Right. And then wrapped around focusing on the cost, our ultimate focus is on the patient. So we're making sure that the right pre-medications are prescribed for the patient to prevent any infusion reactions, and then monitoring that patient for a response to the therapy. And if we don't see the response that we anticipate, then we would call the physician and discuss if continuing therapy is appropriate. Again, introducing another opportunity to lower medical costs and drug costs.